And as the slide's coming up here, I just have a few points I want to bring up about some sort of current topics in pediatric imaging. Some of these may apply to adults, but I'll talk about these three sort of generic topics: a cumulative effective dose or recurrent imaging paradigm, which is somewhat contentious at this point. Diagnostic reference levels, not so much what they are, but sort of what they aren't and what they need to be. And that related topic, the third one, is beyond dose to quality. So how often do we image in terms of recurrent imaging, diagnostic reference levels, when too much is too much, and then beyond dose to image quality, and how important is this? So start with cumulative effective dose. I think the preferred term is recurrent imaging. That is children that get multiple examinations, radiographs, nuclear medicine studies, CT examinations, et cetera. And the two documents that came out that were somewhat at odds with each other was the IAEA statement and then the AAPM organization, together with some other groups, came out with a statement here about 2021. And this dealt with the topic of generally recurrent imaging that results in doses over 100 millisieverts are the ones that we're focusing on. And I will say that while this was put forth in adults, children rarely have this happen. It is actually about 1/100th of the time that you might get recurrent imaging up to this kind of dose in children. And it's most often in oncology settings, which are fairly prescribed imaging algorithms. So, and there's a move to non-ionizing modalities, MR examination, ultrasound, to substitute for these ionizing radiation situations. The issue is the same in adults and children. That is, how should this come into decision-making processes? And I will say that there is some disagreement about whether that should be available to point of care for individual decision-making processes. It is obviously more important when defining protocols, knowing that someone's going to get multiple imaging examinations. And to that end, the IAEA convened a consultancy meeting just recently, a month or so ago, that I was part of here. Salient organizations were present, and I put this up not to tell you what the conclusion was, but to tell you that the conclusion is being formed, and just to stay tuned, because I think we can come to terms and agreement about what the value of recurrent imaging is, the role of that in decision making, and so on. So I just want to introduce this as a topic that is important, although in children it's much less important in adults. And for the white paper for this, again, we're going to provide factual comment, the approaches and perspective that we agree on, those differences that are potentially reconcilable between major organizations, professional bodies, what differences remain, and what significance those differences might be, and then provide remaining needs and actions for things that are universally applicable. So stay tuned. The next, diagnostic reference levels. And I think you're all familiar with the concept and what these involved in terms of ways of benchmarking practice, whether at the local level, the national level, the international level, et cetera. And I just listed sort of the background for what DRLs are fundamentally. We did a study in the United States with CT. It was the first of its kind, and there were about 1.5 million children in this. And I'm just putting this up to say that many countries have contributed to this. Many countries are contributing to this, and it is important to do. And we found out some interesting things, such that what we do in the United States is fairly harmonious for what's done around the world. And I'm not putting this up there to tell you what we did and what we found out in comparison, but to have you understand that this is still problematic with it. For example, in comparing studies, some used patient age, some used patient weight, some used effective diameter. Some used the size-specific dose estimate, some did not. And so comparing these studies was very difficult. And I know there are some recommendations out there for what should be done for diagnostic reference levels, but the fact is people have not come to terms with this so far. Different age classifications, how you classify a CT examination, et cetera. So for those of you who've done any work in this, it is a difficult thing to do. It's very resource heavy. And it's really an exposure. You know, we talk about diagnostic reference levels. I think it's really a dose reference level. It has nothing to do with diagnosis, and I'll get to that point for my third point here. And what we really have is a spectrum of things where we're very far down on the gray side of things there, just representing. It's a surrogate for image performance. It's a surrogate for risk. All we're saying is dose. It's not even dose, it's really exposure. So as you move through that scale, what we need to move towards is ultimately defining what patient risk is. That's why radiation protection is there. It's not a number dose, it's what do we do to improve the healthcare to minimize the risk. So we have some ways to go with diagnostic reference levels. They're very resource consuming, particularly when you consider children, because you've got all these different age categories. And then if you add indication-based DRLs and so on, and the amount of time it takes to do this, you just have to be careful that when you design a program, you don't overcommit to doing these things. Otherwise, you do it once, and 10 years later, you say, oh, is it time to do it again? So you need to be mindful of that. The application, even though DRLs are present, do people really use them to adjust their practice? Maybe at the local level. I'm not sure at the national level. They are benchmarks, are guidelines, but the ability to impact practice is not clearly stated. And they're outdated with new technology like photon counting CT, for example. It's going to change what the diagnostic reference levels are. And I think the PEDS DRLs that were established a number of years ago, the most comprehensive to date, are probably outdated based on new iterative reconstruction and so on. So my final slides here are we need to move towards quality. Two presentations here that just say this is what we need to move towards. One investigation has sort of addressed this, but it's just an observer study. And any of you who have done observer studies, they're tremendously time consuming, and it's not a good way to do that. So what we need to move towards in terms of the quality component, in addition to dose or diagnostic reference levels, is have a quality reference level. And at Duke, we've developed ways of automated noise assessment for a CT examination, spatial assessment, so we can get a number there that you add to the DRLs there. So we need to combine dose with quality, and that is the true measure of CT performance. And finally, we need to be better at establishing the risk of CTs. And this was put out by the national academies saying this is what we need to do for low-level radiation. And these kinds of articles with some connection between dose and risk are coming out. So we need to fundamentally establish better science with respect to low-level radiation risk. So we still have work to do. I just wanted to present briefly a few things I think that are salient to children, some of which to apply to adults. But as I said, for all we've done, we still have a lot to do. So thank you for your attention this afternoon.
Thank you very much, Dom Fresh. And now we move to the next speaker, our dear friend,